All right, we'll go ahead and get started with today's webinar. Thank you for those of you who have joined the call or are watching the video at a later time. I just wanted to, first of all, make note of this webinar series in general. We have a website, and you can just search for that online if you don't have the link handy. It's just UC Health Liver Transplant Webinar Series. And this is the last of this current calendar year's webinars, but I would just do want to recognize that some of my colleagues gave the talks on this webinar series earlier this year. So Dr. John Rice gave a talk earlier this year on the approach to alcohol use in the context of transplantation. Our post-transplant colleagues, Megan O'Meara and Brittany Henderson, gave a talk on post-transplant management. Whitney Jackson, our medical director of living donor liver transplant, gave a talk on that topic a couple of months ago. And then my colleague, Dr. Michael Chris, gave a talk on the management of portal hypertension and its complications. So those were the talks that we gave in 2023. We'll have another series of talks in 2024 as well. So that's something to hopefully look forward to. Today's talk is on liver transplantation evaluation, and this is obviously a very broad topic, so we'll touch on a lot of different aspects as they relate to evaluating patients for liver transplant. I do want to point out that at the end, we'll leave time for questions and discussion. And so while I'm talking, please feel free to put your comments or questions in the chat or Q&A. And Christy Click, who has been really helpful to help set this up, is also providing some information in the chat regarding leaving questions there, as well as CME. So without further ado, we'll get started. So disclosures, I have no financial relationships to disclose, nor do any of the faculty planners or individuals in control of this content today. We do offer CME as well as nursing credit. These are slides that will be available on the recording, which will stay on the website, so you can refer to this later, and we'll also include the CME information in the chat as well. And again, as I mentioned, also nursing continuing professional development credit is offered for this as well. So learning objectives today, number one, just to start, before we even get to talking about evaluating patients for liver transplant, I'd like to talk about the global burden of liver disease and understanding that as it has increased over time. Number two, review the indications for liver transplantation and the modern use of the MELD score. And number three, develop an understanding of the multidisciplinary care involved with evaluation for liver transplantation. So the global burden of liver disease, I mentioned this, has increased over time. These are just some numbers to give you just a general idea. And these are large numbers that are sort of hard to comprehend sometimes on a large scale. But from the data that we have from 2017, almost 11 million prevalent cases of decompensated cirrhosis. In 2021, deaths due to cirrhosis were made up 2.4% of total deaths globally, and that should say, excuse me, in 2021, not 2017. And the estimate for this year is that 2 million deaths worldwide will be attributed to cirrhosis. As a result of the increasing burden of liver disease worldwide, the number of liver transplants has increased. Almost 35,000 liver transplants in 2021 were performed. Globally, 23% of these used living donors. And this is overall, in terms of the overall number of liver transplants, an increase of about 6.5% from 2020, and remarkably a 20% increase from 2015. So talking about year after year, a significant increase in the amount of liver transplants that are performed in the world, with increased use of living donors as well. And we'll talk about some of these topics as the talk goes along today. This is just a map showing the number of liver transplants worldwide per million people in population per country. I do want to point out that several of these countries are shaded in white, and that represents that the data is actually just not available for those countries. But generally speaking, liver transplant is not offered in those countries that remain white on this map. No transplant activity is gray, and the darker shade of blue or purple represents more liver transplants. And so you can see the majority of liver transplants worldwide are performed in North America, South America, and then parts of Europe and the Mediterranean. One of the reasons I show this map as well is because there's a significant burden of liver disease in the parts of the world that are not performing liver transplants or where liver transplant is not widely available, and that includes Africa and parts of Asia. Well, how about in the United States? So in the US, the number of liver transplants has increased about 18 to 20% in the last 5 years, and we now perform over 9,400, and it's approaching 10,000 liver transplants per year. The greatest proportional increase is occurring among living donors and a greater utilization of higher risk donors as well. But this is all in the context of a changing landscape of chronic liver disease to begin with. So the etiologies of liver disease that we see leading to liver transplantation have changed significantly. Before I get into that, I do want to just comment on this because there's new nomenclature to be aware of. So this is sort of late breaking just within the past calendar year, and our medical societies have adopted new terms for what was previously the umbrella or spectrum of fatty liver disease, now referred to as steatotic liver disease or SLD. The term non-alcoholic fatty liver disease is now metabolic dysfunction associated steatotic liver disease, so MASLD. And NASH is now MASH, metabolic dysfunction associated steatohepatitis. So a bit of alphabet soup, but just to keep in mind that I'll be using the new terminology as we go through this talk, and likely my colleagues will be using the new terminology as we go through subsequent talks as well. So I mentioned the changing burden of liver disease in patients requiring transplant. This is in the United States, but you can see that over time, a decrease in viral hepatitis, specifically hepatitis C, and that's of course due to the wide availability of direct-acting antivirals, while simultaneously, there's been an increase in alcohol-associated liver disease and MASLD. So again, metabolic dysfunction-associated steatotic liver disease. Alcohol consumption has increased in the United States over time. This is a graph just showing that, especially at the start of the COVID-19 pandemic, there's been an increase in alcohol sales. Paralleling this is a phenomenon that we've all seen in our medical practices of increased, especially young patients presenting with decompensated alcohol-associated liver disease, specifically alcoholic hepatitis, which is a topic that I'll touch on a little bit later in this talk in terms of how we approach that particular condition in the context of transplantation. 60% of people increased their alcohol consumption since the start of the pandemic. Worldwide, the annual per capita consumption of alcohol is 6.5 liters of alcohol. It's hard to put that into sort of terms to understand, but again, 1 liter is considered to have 22 standard shots of alcohol. So we're talking about per capita consumption annually of over 140 shots, and that's worldwide. The global prevalence of alcohol use disorder is 5.1%, and that's only increasing. Especially driven by a variety of recent factors, including the COVID-19 pandemic, which exacerbated underlying problems of social isolation and mental health difficulties. Now, despite treatment advances that I just mentioned with hepatitis C, I do want to just mention that viral hepatitis does remain the main cause of cirrhosis and liver cancer in Southeast Asia, Africa, and the East Mediterranean regions. It's pretty remarkable, actually, just the degree of prevalence for viral hepatitis, especially hepatitis B and C. Each year, worldwide, there are about 1.5 million new cases of hepatitis B and about 1.5 million new cases of hepatitis C. But worldwide, only about 20% of those hepatitis C cases are even diagnosed, and less than 10% of those hepatitis B cases are diagnosed. So you can imagine that these undiagnosed cases lead to chronic liver disease and potential need for liver transplant in the future. Now, in the US and Europe, there have been dramatic decreases in hepatitis C as the indication for liver transplant since 2014. That's when direct-acting antivirals became widely available. They were certainly available before then, but in terms of common use throughout US and Europe, 2014 is when we started to see that decrease. Alcohol-associated liver disease is the most frequent indication for liver transplant in Europe and in the United States. But steatotic liver disease has been increasing rapidly, and it's anticipated to become the most common indication for liver transplant in many countries within the next decade. At any given time, it's number 1 or number 2 in the US, even right now, and it's currently the leading indication among females. The proportion of liver transplant for MASH, so again, metabolic dysfunction associated steatohepatitis, was only 2.5% in 2004, so not even 20 years ago, and it's now over 20% in the United States. And just as a reminder, when we're talking about this condition of metabolic dysfunction associated steatotic liver disease, this is a spectrum ranging from steatosis, where fat is accumulating in the liver, to the addition of inflammation and scarring, so steatohepatitis, that's MASH, to, in a small percentage of patients, the development of scar tissue or fibrosis, when it reaches a nodular level within the liver. That's when we call that cirrhosis, as you can see on the histopathologic photo there. And so again, I'm painting the picture here that within the context of our practice, there's been an evolving change in the patients that we're seeing. So the recipient phenotype, they're older, more obesity. Again, that's reflecting not just the obesity epidemic, but increased frequency of comorbidities like cardiovascular disease and high cholesterol. Transplant indication has changed, less hepatitis C, more metabolic dysfunction associated steatotic liver disease, more alcohol, non-HCC or hepatocellular carcinoma oncologic indications, and the disease severity has changed as well. Higher acuity, higher MELD scores across the country, more alcoholic hepatitis and acute on chronic liver failure, and then even expanded criteria for the patients we even consider for hepatocellular carcinoma and transplant. And so within all of that context, liver transplantation is indicated for severe acute or advanced chronic liver disease when the limits of medical therapy have been reached. And that's been a sentence that's remained in our AASLD guidelines for many, many years. Of course, there are some conditions where therapies may improve hepatocellular function, such as antiviral agents for chronic hepatitis B or steroids for autoimmune hepatitis. And as a reminder, that recognition of cirrhosis per se does not imply a need for transplantation, but it does require monitoring for complications that may warrant the need for transplantation in the future. That includes hepatocellular carcinoma, portal hypertensive complications such as varices or ascites, hepatic encephalopathy, and then sarcopenia or frailty as well. Still, there's a challenge that we all face as we take care of our patients with chronic liver disease who may need transplant. There's a chronic organ shortage that is unlikely to be solved anytime in the near future. And so as a result, we're tasked with minimizing waiting list mortality. So patients who are awaiting transplant, we're minimizing their mortality, clearly, but we also want to guarantee excellent post-transplant survival. It doesn't make sense to transplant patients who are going to do poorly and not even survive, for example, 12 months after a liver transplant. I think that we could all agree that such a practice would not only be unfair to the patient to undergo such a procedure for a poor outcome, but it also wouldn't be fair and equitable to patients who require transplant and would have excellent post-transplant survival. And so within that context, within that challenge, efforts have been made during the last several decades to refine allocation policies on one hand and distribution policies. And those two things are different. Allocation certainly is how we think about patients awaiting transplant, how they're going to get to the finish line of transplant. Distribution policies is how livers get geographically, again, distributed throughout the country. And there have been many changes regarding distribution, which are outside the scope of today's practice, of today's talk, but we'll focus on the allocation policies. So first of all, the MELD score. I know that many of you watching this or listening to this are familiar with this, but again, it stands for the Model for End-Stage Liver Disease. It was adopted formally in 2002 as the foundation of the liver transplant waiting list in the United States and has since been adopted in many countries worldwide. It didn't just get developed in 2002, though. It was actually around for a few years before that, as it was initially developed at the Mayo Clinic to predict mortality following placement of a TIPS, or transjugular intrahepatic portosystemic shunt. And we still do use the MELD score for that initial indication. And the MELD score and I'm going to talk about the recent evolution of this, but the MELD score that most of us have been using for the last many years has included the following variables: the serum creatinine, total bilirubin, INR, and serum sodium. Sodium was added to the MELD score in 2016 after many years of data showing that the development of hyponatremia is a marker of increased waitlist mortality in patients with decompensated cirrhosis, independent of their prior calculated MELD score that did not include the sodium. And this is a very famous graph in transplant hepatology showing kind of the initial data of how we thought about the MELD score and survival. And you can see the overall point I want to emphasize here has not changed. Increased MELD score, decreased survival, and there's a significant drop-off, as you can see, especially after a MELD of 25 or 26. So a MELD score of, for example, 10 has, a 90 to 100% 3-month survival rate. A MELD score of 40 would have an over 90% chance of mortality within 3 months, conversely. Typically, based on this graph, we would have said for many years that the typical threshold MELD for transplant evaluation was 15. You can see that that's where the curve starts to decrease rapidly to the point where we would have argued that the benefit of transplant starts to outweigh the risk of transplant. That's changed a little bit, and I'll get to that momentarily. Now, a little bit more about the history of the MELD score. Well, first of all, this is a sickest first policy. This is what the transplant community was tasked with creating in the early 2000s. So it's a MELD-based sickest first policy. Importantly, it did not result in worse post-transplant outcomes. So I talked about the challenge earlier about how we want to make sure that patients after transplant do well. So it didn't result in worse post-transplant outcomes. So that's good. Various allocation systems have been developed to prioritize patients over the years with hepatocellular carcinoma, with periodic adjustments to ensure equity between other patients with decompensated cirrhosis versus HCC by modifying that. And I'll talk more about that in a little bit. And like I said, the 2016 was a big year because it incorporated the serum sodium into the MELD score. And that change did result in a modest improvement in the accuracy of waitlist prediction of mortality. So all of the historical changes, again, have been to make sure that the allocation is fair and ensures the adequate post-transplant outcomes that we would come to expect. But there are limitations to the MELD score. First of all, the prognostic impact of impaired kidney function in cirrhosis is well known. I think we've all seen patients with who develop kidney impairment in the setting of decompensated cirrhosis as a result of the complex pathophysiology of those patients. So we understand that these patients with impaired kidney function generally don't do well in the long run. But the use of the serum creatinine as the marker, the surrogate marker of renal function, is inaccurate. It's not a again, it's an estimated function marker of the GFR, or the glomerular filtration rate. Actually measuring the GFR directly would overcome the inaccuracies, but actually measuring that requires measuring clearance of various exogenous agents. It's costly, time-consuming, impractical, and wouldn't be widely available outside of a research setting. So that's a problem. Secondarily, women, on average, with a lower muscle mass, have a lower serum creatinine than men for the same degree of renal dysfunction. And so this negatively impacts their MELD score and underestimates the severity of their disease, therefore decreasing their fair access, or fair and equitable access, to liver transplantation. This was borne out in many studies over the past decade, showing that females have decreased odds of liver transplantation within 3 years of listing compared to males. Again, that's for the same MELD score. And females are more likely than males to die waiting for transplant, and they're also more likely to be removed from the waitlist for being too sick for transplant. So there's clearly a sex disparity that had developed as a somewhat unintended consequence of the MELD score. Other limitations that I've listed here, just briefly: serum sodium, well, it can be manipulated with diuretics. The INR measurement varies according to the reagent used, the type of measuring device. Worth noting that there's some bias here in patients who are receiving vitamin K antagonists, such as warfarin, which would, of course, increase the INR. And sometimes we do that for patients who have a portal vein thrombosis or mesenteric thrombosis that we don't want to extend. And so that may artificially over-prioritize those patients. The MELD score was also developed when chronic hepatitis C was the leading indication for liver transplant. So we talked about the changing landscape of chronic liver disease over the last 2 decades. Those patients with chronic hepatitis C who are untreated, this is before direct-acting antivirals, tended to have higher bilirubin levels. And so the bilirubin was prioritized in the original MELD calculation. But now there's been an increase in MASH-related cirrhosis, and bilirubin tends to actually be lower than patients with chronic hep C or alcohol. And so the weight given to bilirubin has been questioned. Certainly don't have to know or memorize these equations, but this is just showing that this is a complex calculation that is logarithmic and includes changing coefficients. So there's the MELD score, MELD sodium, and now to get to the point, this is the new MELD score that we use, which is MELD 3.0, which some of you may remember, depending on your age, a time in the 90s where we had AOL 3.0. This is just a reminder of what that looked like, which is somewhat remarkable, but I think the MELD 3.0 is a little bit more advanced. So this adds 2 new variables, current sex as well as albumin. It also updates coefficients for existing variables. Again, the existing variables being what I mentioned earlier: sodium, bilirubin, creatinine, and INR. It introduces some interaction terms between bilirubin and sodium and between albumin and creatinine, and it caps the creatinine at 3.0 as well. This is the equation. Again, not something to memorize, but the point is that this is complicated, and you can see just the first part of the equation that there's an increased, you're going to have increased MELD score if your current sex is female, due to that coefficient of 1.33, which would, in most patients, add a point or 2 to the MELD score. We, meaning the transplant community, we didn't do this without data, of course. And basically what was done prior to the implementation of the MELD 3.0 was looking back at many years of outcomes, specifically waitlist deaths in this case that I've shown on this particular slide. And we found that the MELD 3.0 better predicts candidate waitlist mortality compared to MELD sodium. And if we had been using the MELD 3.0 with albumin, we would have potentially avoided at least 60 waitlist deaths during that study period. And so the MELD 3.0 score, while it had been studied for some time, and while that data was being collected, so we were aware of it as a transplant community, it was just earlier this year that the MELD 3.0 officially became the MELD calculation that we use nationally in the allocation for liver transplant. So it has that traditional threshold of a MELD of 15 change. Again, the threshold specifically to evaluate a patient for liver transplant. I showed that graph earlier, and we would say it was sort of the traditional teaching that a MELD of 15 or above requires a transplant evaluation. So has that changed? I would say yes. So this is a graph showing, first of all, 90-day mortality with or without moderate ascites across the MELD spectrum. So this shows that essentially, so you can see in the solid line, that's patients with moderate ascites. The dashed line is no or small ascites. X-axis is MELD score. The Y-axis is 90-day mortality risk. And you can see that at every MELD score, the presence of moderate ascites increases mortality compared to patients with no or small ascites. And this was specifically calculated that a patient with moderate ascites, as an example here, and a MELD of 11 has an equivalent risk of death as a patient with no or small ascites and a MELD of 16. So again, a MELD of 11 with ascites has the same risk of death as a patient with a MELD of 16 and no ascites. And so this just emphasizes the point that the MELD score, just being a number, doesn't sometimes reflect true mortality risk, especially with patients with ongoing decompensations. Another 4 to 5 MELD points would actually adjust for the observed increase in mortality in patients with ascites and a MELD under 21. Each year, 20% of patients awaiting a liver transplant in the United States die or become too sick for transplant. And so that demonstrates a severe shortage of donors and emphasizes the need to increase the donor pool. These are several of my colleagues, and I mentioned Whitney Jackson earlier, who's our medical director of liver transplant here at our transplant program at UC Health, published this showing the survival benefit of living donor liver transplant in JAMA Surgery last year, but it also emphasizes the point I'm making about the MELD score in general. It showed that again, this was a case-controlled study. It looked at about a decade worth of transplant candidates and recipients, over so almost 120,000 patients. So a huge database, and showed that patients with a MELD score, again, this was using the MELD sodium calculation, patients with a MELD score as low as 11 had a 34% decrease in mortality with transplant compared with those who remained on the transplant list. Further analysis showing that patients who received a living donor liver transplant can be expected to gain an additional 13 to 17 years of life compared to those who never received a transplant. So not only does it emphasize the importance of patients being evaluated at a center that can offer a living donor liver transplant, but it also emphasizes the fact that a MELD score as low as 11 has a transplant benefit, specifically with a decrease in mortality compared to patients not getting transplanted. And that changes that whole concept I talked about the threshold MELD of 15. And so when do we say to refer patients for liver transplant at this point? So a MELD score over 11 to 12, regardless of complications. Any complication of decompensated cirrhosis, regardless of their MELD score, so ascites, which of course can lead to spontaneous bacterial peritonitis, variceal bleeding, hepatic encephalopathy, portopulmonary hypertension, hepatopulmonary syndrome. Cancers meeting certain criteria, so hepatocellular carcinoma within Milan criteria, perihilar cholangiocarcinoma meeting what's called the Mayo criteria. And though that's a separate topic entirely, generally speaking, that refers to early stage perihilar cholangiocarcinoma is less than 3 centimeters, that are in patients who can also tolerate neoadjuvant chemotherapy. Quality of life is something to consider too. So some of these patients are sicker than their MELD score. For example, patients with primary sclerosing cholangitis who experience recurrent episodes of cholangitis, patients with PBC or primary biliary cholangitis who have refractory pruritus, patients with malnutrition and sarcopenia who are sicker than their MELD score. These are all indications to consider referral for liver transplant. We always say this, but I do want to emphasize the point. It's better to refer a patient earlier when their MELD score is 12 or 13 and you're not sure if they're too early, than waiting till it's too late and their MELD score is 40, they can't walk or even tolerate dialysis and are too sick to get a transplant. Again, a topic that's an entirely separate talk, but just one slide on HCC criteria, just to emphasize the point that that we transplant patients for hepatocellular carcinoma. It was actually, like I said earlier, one of the indications for transplant that's evolved significantly over the past several decades. The Milan criteria refers to a single HCC diagnosed radiographically, typically between 2 and 5 centimeters, or up to 3 lesions that are all 3 or less centimeters. You can be outside Milan criteria, meaning have a tumor, for example, up to 8 centimeters, or multiple lesions with the criteria that I mentioned there, and then be downstage with locoregional therapy such as Y90 radiation or TACE, which is transarterial chemoembolization. These are therapies performed by interventional radiologists. And you can be downstage to within Milan criteria. And these are criteria that allow for an exception, a MELD exception. So I mentioned earlier this concept that there are patients who are sicker than their MELD score. This has historically commonly applied to patients with HCC or hepatocellular carcinoma, where their MELD score might be 6 or 7. But we know from lots of data worldwide that the median survival of a patient with HCC is 18 months. And so if somebody with a MELD of 6 or 7 is listed for transplant, unless they have a living donor, they're not going to get a transplant with a deceased donor because their MELD score is too low. And so a system is put in place where patients get prioritized and actually moved up to close to the top of the list. And again, that's a topic that has evolved significantly in terms of how many points that you're able to accrue and when. But the concept is simply that we can prioritize these patients for transplant despite a low MELD score. Now, despite increasing number of transplants, I talked about how the number of transplants has grown in the US and worldwide. There's still this gap. The wait list additions in the green line here has been increasing. And despite transplants increasing, there's still a gap, and the wait list reflects, therefore, a limited resource. So when we evaluate patients for transplant, it's a complex process. And I want to spend some of the rest of the talk here going over the components of a liver transplant evaluation, as well as how we approach certain issues that may come up during the evaluation process. So first of all, the liver transplant evaluation typically occurs at most centers over a 2-day span. We have a system in place at our center where patients are here for about a day and a half, going through their evaluation process prior to a review of their evaluation by our transplant selection committee within a week or so of them undergoing their evaluation. So first of all, we secure financial or insurance approval for a liver transplant evaluation. The components of the evaluation include meeting with a transplant hepatologist, such as myself or one of my partners. And this allows us to assess their disease severity, confirm their diagnosis, optimize their management, and to be their advocating hepatologist potentially as they go through this process. They undergo a surgical evaluation, so they meet with a transplant surgeon, of course, confirming the need for transplant, identifying technical challenges, so prior abdominal surgeries, portal vein thrombosis, discussing donor options. So again, deceased donation versus living donation, for example. Laboratory testing, and this includes checking their blood types, ruling out other causes of liver disease, checking viral serologies, to make sure that they're up to date on vaccinations, checking a urine drug screen. We make sure that our patients undergo a cardiopulmonary evaluation. Now, these are in the AASLD practice guidelines, and it's it essentially mandates that every patient undergoing a liver transplant evaluation undergoes a evaluation with an echocardiography, but it's kind of up to each transplant center after that in terms of how we go about screening for coronary artery disease. At our center, we perform a coronary CTA to screen for coronary artery disease, and some patients may require a left heart catheterization, especially if there are cardiac risk factors or an abnormal coronary CTA. Certainly, we would get hepatic imaging. Most patients coming for our transplant evaluations have already received this, but we get updated imaging to ensure that their portal vein is patent. This is for many reasons. One is to rule out any potential for tumor in the portal vein, but also to make sure it's patent to allow for a healthy surgical anastomosis at the time of transplant. We require a general health assessment, so chest X-ray, pap smear, and mammogram in women, colonoscopy if a patient is aged now 45 and older, based on current guidelines, of course. Dental assessment is part of our sort of evaluation, usually done actually by the hepatologist who's seeing the patient, and we can identify whether the patient might need dental care prior to transplant. We have an anesthesia evaluation, again, reviewing pulmonary function tests, reviewing the echocardiogram, reviewing any risk for anesthesia that they need to be aware of at the time of transplant. Patients undergo an extensive psychological evaluation. So this includes, in many cases, seeing a transplant psychologist or psychiatrist to discuss history of substance abuse, psychiatric illness, and discuss the need for therapy for those disorders. A social work evaluation is really tied into that as well. So addressing potential psychosocial issues. adequacy of support. So again, patients need to have social support to be a transplant candidate. That typically requires either family members, a close network of friends, typically someone or multiple people who can live with the patient before and after transplant, to ensure that these patients do well, especially in those first few months after transplant. We get a nutrition evaluation, so they see a transplant dietitian, and then also an infectious disease evaluation as well. So identifying any infectious processes that we would need to intervene on, such as latent TB, and even HIV as well. Now, are there contraindications? I think these are commonly asked questions, and there's some asterisks here, and I'm going to hedge a little bit in some cases because ultimately a transplant evaluation is very tailored to the individual patient. There are some, absolute contraindications that would apply in essentially all cases, but there are always caveats that we have to consider. So generally speaking, contraindications to transplant: advanced cardiac or pulmonary disease. So when I say advanced cardiac, I typically am referring to patients with heart failure or severe coronary artery disease that would not be amenable to a straightforward PCI therapy. So, for example, multi-vessel coronary artery disease that would otherwise require bypass grafting would not be would not allow for an indication for transplant. Severe pulmonary hypertension would be a contraindication. Untreated AIDS, active alcohol or illicit substance use is generally speaking a contraindication. Now, certainly alcoholic hepatitis is a growing indication for transplant that I'll talk about in a moment, but generally speaking, active alcohol use in a cirrhotic patient is a contraindication. Metastatic spread of HCC or cholangiocarcinoma is a contraindication. Untreated septic shock or sepsis. An anatomic abnormality that would preclude, for example, an anastomosis being safely performed at the transplant. An active extrahepatic malignancy. Again, this is this may have changed a little bit in the sense that if somebody has, for example, a localized colonic lesion or even a breast cancer that we are confident is local and can be addressed really immediately after transplant, we may still consider transplanting patients in that situation. But generally speaking, an active extrahepatic malignancy is a contraindication. Like I said earlier, a lack of psychosocial support and severe psychologic disease. Profound frailty, so if a patient can't walk, for example. Persistent non-compliance or non-adherence. Advanced age is a contraindication. I'll talk about that in a moment. Extensive previous abdominal surgery in some cases, and extensive portal or mesenteric thrombosis in many cases would be a contraindication, especially if they're not improving with anticoagulation. I'll touch on a few of those caveats that came up in those last couple of slides. So age over 70 is a risk factor for graft loss and mortality, especially in patients with a higher MELD score. Age over 70 is associated with a 1-year graft survival rate of only 56%, and that risk is universal. There's higher mortality in transplant recipients of advanced age in Europe as well as in the United States. And so as a result of that, and you can see that here too, age over 70 being the solid line, with significantly decreased graft survival. As a result of that, we consider age over 70 to be a contraindication in almost all cases for liver transplant. How about obesity? Well, BMI over 30 increases the perioperative risks. It reduces survival in the long run, but also in the short term, these patients have longer hospitalizations, increased risk for infection, return to the OR, and the increased need for post-transplant rehab. So obese patients with a BMI over 30 or greater are referred to a dietitian. BMI over 40 is considered in most cases at our center to be a relative contraindication for a liver transplant. How about pulmonary hypertension? Again, this is one of the factors I mentioned that we're looking for on, for example, an echocardiogram. One question that comes up is, well, does the patient have portopulmonary hypertension? I just do want to mention that in very select patients with portopulmonary hypertension, which is a condition where patients have primary pulmonary arterial hypertension as a consequence of their portal hypertension. In moderate to severe cases, this is associated with a higher mortality rate after transplant. And if their mean PA pressure is above 50, essentially the mortality rate with transplant is 100%. So we would not consider transplant in that case. It's diagnosed, as I said, by echocardiogram initially, but if severe, we would proceed with a right heart catheterization as the gold standard to confirm the diagnosis and also to guide treatment, which would include vasodilator therapy. Liver transplant in patients with portal pulmonary hypertension who respond to vasodilator therapy and reducing their mean PA pressure to under 35 millimeters of mercury are actually candidates to receive one of those MELD exception points that I alluded to earlier. Tobacco use, as we talk about this a lot with our patients, cigarette smoking is implicated in a number of adverse outcomes in liver transplant recipients: cardiovascular mortality, increased incidence of hepatic artery thrombosis, for example. Oropharyngeal and other neoplasms following transplant are also linked to cigarette smoking. And some transplant programs, including ours, make cigarette cessation a condition for listing for transplant and require negative serial nicotine screens for documenting cessation. I want to talk for the next few slides a little bit about the concept of nutrition. And I know I'm bouncing to a lot of different topics here, but we're considering all of these issues when we're evaluating patients for transplant and trying to optimize their candidacy. This is a really big topic. So cirrhosis is, first of all, a catabolic chronic illness. It's often accompanied by a reduced appetite. We know that malnutrition leads to poor outcomes following transplant with a BMI under 18.5. The severity of muscle wasting in these patients is often masked by ascites and obesity. And for a long time, there was a misconception regarding protein intake with the thought that increased protein intake may worsen hepatic encephalopathy. But there's certainly no need to limit protein intake for patients with chronic liver disease because that will only exacerbate their muscle wasting and malnutrition. There are actually AASLD practice guidelines on this topic that were published in 2021. So this is a resource if you need it in your practice: malnutrition, frailty, and sarcopenia in patients with cirrhosis. So what is malnutrition? Well, it's defined as a clinical syndrome resulting from an imbalance of nutrients that causes adverse effects on tissue, body, form, function, or outcome. And it's important to recognize that malnutrition represents a spectrum of nutritional disorders in patients with cirrhosis across the entire range of BMI, as I've emphasized earlier with the increase in MASH, so from underweight to obese. But it leads to adverse physical effects, and that's really what we end up focusing on because they're phenotypically, these patients commonly present as frail or sarcopenic, literally a deficiency in sarcomeres. I mentioned earlier that this was borne out in an important paper back in 2015 out of our center, showing that low rather than high BMI confers increased risk for post-liver transplant death and graft loss. And so this all leads to frailty in our patients, a clinical state of decreased reserve and ability to endure health stressors. When we're talking about patients with cirrhosis, the operational definition of frailty is physical frailty. So the loss of muscle function leading to negative consequences. Frailty is present in over 30% of patients listed for liver transplant, and it's strongly linked to increased waitlist mortality, decreased quality of life, and increased hospitalizations. It also worsens longitudinally without intervention and may even persist following liver transplant. This is a complex slide, but just showing that there's a lot of factors that go into this. So it's not just malnutrition leading to frailty, but physical inactivity, cirrhosis-related complications, and environmental factors as well, such as social determinants of health. These lead to frailty. That in turn leads to increased decompensation, decreased health-related quality of life, death, and adverse post-transplant outcomes. We measure frailty objectively in our clinic during the transplant evaluation with a tool called the Liver Frailty Index. For the sake of time, I did not include that particular scoring system in today's talk, but you can certainly look that up if you're interested. It's a nice objective measure of patients' frailty that can actually be followed longitudinally. I touched on this already, but again, malnutrition, cirrhosis factors, systemic inflammation, physical inactivity, and social determinants of health are all factors that lead to the development of frailty in our patients. And so as part of their frailty testing, their meeting with our transplant dietitian, and their preparation for transplant, we emphasize the importance of protein intake. So specifically an intake of 1.2 to 1.5 grams per kilogram per day for adults with cirrhosis. This allows us to maintain in our patients a positive protein balance. It also does not worsen hepatic encephalopathy. So that's just an important point that we always emphasize. Prolonged fasting should also be avoided, and this limits the exacerbation of that catabolic process in patients with cirrhosis. So evidence supports an early morning breakfast or late evening snack in our patients, as well as their increased protein intake during the day. And in patients who are not able to achieve this orally, we strongly advise and in many cases mandate, especially if patients are nearing transplant, enteral supplementation, so tube feeding. In patients, like I said, who have failed oral supplementation. And so in patients who are critically ill, a higher protein target of 1.2 to 2 grams per kilogram per day is recommended. Now, just to sort of quickly summarize what we've talked about the global burden of liver disease. We've talked about the changing indications for transplant. We've talked about the evolution of the MELD score. We've talked about the transplant evaluation process and how we approach things like cardiopulmonary disease, tobacco use, and frailty. But perhaps the most commonly encountered question that we get as transplant hepatologists nowadays is, should we, what's our approach to alcohol use and sobriety, and specifically, should we be transplanting patients with acute alcoholic hepatitis? So should patients be referred for transplant with alcoholic hepatitis? Again, this is a severe inflammatory condition, different from decompensated cirrhosis. These are patients who have drank alcohol in excess for shorter periods of time, typically months to 2 to 3 years. And we've seen an increase of this condition, like I alluded to earlier, in the context of the COVID-19 pandemic. We do suggest that some of these patients, again, it ends up being a small percentage of all patients with alcoholic hepatitis, but there are patients that we acknowledge would benefit from transplant and that we do transplant for this condition. And typically, these are patients with severe steroid refractory or intolerant alcoholic hepatitis. Importantly, no previous knowledge of their liver disease. So this is typically patients who are presenting as a first-time initial index presentation. This is not a patient who has been to the ER with alcohol intoxication or alcohol withdrawal, multiple admissions for alcohol-related liver disease, and then develops alcoholic hepatitis. That's not a patient who would typically be considered for transplant in the early period. No concomitant substance use, and a favorable quote-unquote psychosocial profile. And of course, this is a concept that we would measure with the assistance of addiction medicine specialists, psychologists, and social workers. Is there a 6-month rule? Do patients have to be sober for 6 months before being referred for liver transplant? No, absolutely not. The 6-month rule is a historical concept that was thought to potentially improve outcomes, because the thought was that this would allow time to determine if the liver function could improve and patients could even avoid transplant. But what we've learned over time is that 6 months of sobriety as an arbitrary time period is a poor predictor for alcohol relapse for many reasons. It encourages dishonesty. It does not encourage alcohol use disorder treatment, which is perhaps the most important thing early on for many of these patients. It's also an unrealistic barrier to transplant. 75 to 90% of deaths in patients with alcoholic hepatitis occur within the first 2 months, sometimes due to worse progressive liver disease, many times due to infection. If we're mandating a 6-month rule for these patients, we're missing the opportunity to help several of them who may benefit from early liver transplant. So patients who have insight into their alcohol use disorder, who have social support, who have a perception of negative consequences of alcohol use, these are protective factors that would support their candidacy. Negative factors, like I alluded to, are other psychological disorders or psychiatric conditions, repeated attempts at rehabilitation that have failed, social isolation, and unremitting substance use despite physical and social consequences. These would be negative factors. And these are factors that we weigh as we consider patients' transplant candidacy. There is data to support early liver transplant for alcoholic hepatitis. So this is the initial paper out of France that included 26 patients, severe alcoholic hepatitis that did not respond to steroid treatment. And in liver transplant recipients had a 6-month survival here of 77% versus 23% in the patients with alcoholic hepatitis who did not get liver transplants. In the US, this shows that this was a multi-center consortium, the Accelerate AH trial. Again, early transplant, no specific sobriety period. This had 147 patients as opposed to the 26 from France. And this showed 1-year survival of 94%, 3-year survival of 84%. These are percentages that are in line, by the way, with post-transplant outcomes for any indication. And sustained alcohol use after transplant was 10% at 1 year and 17% at 3 years. Now, while in a perfect world, those numbers would be 0, we understand that treating alcohol use disorder is complicated. We do our best to support these patients, not only pre-transplant, but post-transplant as well. And know that if the numbers were 0% of sustained alcohol use after transplant at 1 year, we'd probably be we would probably be being too selective. And so as a result, a percentage of sustained alcohol use after transplant is expected for the benefit that we gain in the majority of patients, on the other hand. At the University of Colorado, to transplant patients with alcoholic hepatitis, candidates must admit to alcohol use, certainly, demonstrating insight. They should demonstrate commitment to lifelong abstinence, should not have coexisting psychiatric disorders. They should be able to engage in the evaluation process as well. So they can't have high-grade encephalopathy and be too sick to engage with our psychosocial team. They should have strong social support, no other contraindications to transplant. And they should be a candidate or be willing to engage in counseling after transplant as well. And so at our center, we've actually partnered with an addiction medicine service on our campus to help with treating these patients' alcohol use disorders after transplant, and in many cases, contract with basically a behavioral agreement with patients that they sign before transplant to agree to counseling after transplant. And this leads to regular visits, not only with their counselor, but with their hepatologist as well. The last quick sort of tangent I want to make about our management of patients with alcohol-associated liver disease is that we do also advocate for the use of the PEth test, or phosphatidylethanol. I know we've mentioned this on these webinars before, but this is now a widely available test. Even if it's not something that you can get at your particular laboratory or center, the turnaround even for a send-out test is now typically less than a week. And so this is again a compound, phospholipid, formed by the reaction of phosphatidylcholine with ethanol on the red blood cell membrane. Has a half-life of 10 to 14 days, so it sticks around in the blood for up to 2 months in some cases, depending on the degree of alcohol use in our patients. It's kind of like the hemoglobin A1C for alcohol, with a high sensitivity and high specificity using cutoff over 20. And so this is a tool that can be used to monitor patients for alcohol use, as well as to document their sobriety. And so it can be a positive test for patients. What I should say is, if negative, it can be positive for the patient because supporting their sobriety. It's worth noting that blood transfusions can cause a low-level false positive. If patients receives a blood transfusion from someone who's recently been consuming a moderate amount of alcohol, they will have the phosphatidylethanol compound on the red blood cells. So I want to just close by a couple of slides about our liver transplant program. I've talked a lot about our approach to liver transplant evaluation and how we try to take care of our patients. We're very proud that our program is the oldest liver transplant program in the world, having performed the first successful human liver transplant in 1967. We're also the only living donor liver transplant program in the state of Colorado. I've included just a graph there showing our liver transplant volumes compared to other local transplant centers. So we transplant more livers than any other program in the region, but we're also the only program that can offer living donor liver transplant. And based on the data that I showed earlier regarding the MELD score, I would strongly advocate for any patient who's being evaluated for liver transplant to have both deceased and living donor transplants available to them as options. This is our transplant team. I want to emphasize a couple points here. First of all, this is just so that, because I know that many of you watching or listening to this have talked with us on the phone. The 9 of us who are transplant hepatologists here also cover our inpatient service, and we do want to always be available to help. I've listed our amazing advanced practice providers, both on the hepatology side and liver transplant side, but the team really extends far beyond this, includes a number of amazing hepatology nurses, pre-liver transplant coordinators, post-transplant coordinators, other staff, social workers, and the list goes on. And we're very proud to have an amazing team here at UC Health and hopefully be a resource to all of you as well. Regarding being a resource to all of you, we do have a number of liver transplant outreach locations within Colorado. So Loveland, Colorado Springs, Lone Tree, and Grand Junction. I also travel up to Billings, Montana to do a transplant clinic up there, as well as down to Albuquerque, New Mexico. Our post-transplant providers, Brittany Henderson and Megan O'Meara, also travel to Albuquerque and Grand Junction. And all of us in our group do outreach, and we're very proud of that by being able to take care of patients closer to their own home. I'm going to be flying to Albuquerque tomorrow morning for a full day of clinic tomorrow, and I think it's important and it's quite rewarding as well. This is our contact information. We have one of us who, as far as a hepatologist, is on our service 24/7 and can be reached through the doc line. Importantly, I put our phone numbers there for outreach, for clinic referrals, and that includes outreach. That's my cell phone number, and you're welcome to text or call me if we could ever help with any of your patients, and that's my email address as well. Thanks for your attention. Really appreciate your time today. I know we have a few minutes left, and I'll sort of switch over to the chat here so I can address some of your questions. But thank you again for listening. So if you have any questions, you can feel free to put it in the chat or into the Q&A. If I don't see questions, I'll assume that I was extremely clear about everything for the last hour. All right. Well, while we're waiting just to see if any questions come in, I do want to just say, again, thank you for listening. That does conclude the webinar series for 2023. I want to thank many of you for listening to several of the webinars through the course of the year, and also just emphasize that we'll have another series of talks in the year 2024. So just be on the lookout for that. The videos for all the talks are also saved on the website. Each video, after each talk, within a week or two of the talk, the video is posted on the website, so that can be used as a resource for the future. And then lastly, the CME and nursing credit information is on the website as well. Okay, thank you very much. I appreciate your time.